So, Alistair, thank you very much, and thank you, Peter, for the invitation, and hello, everybody. So, as a colorectal surgeon, I know, and I hope you'll all agree, surgery has an important role in the management of many solid tumours. So, when the surge happened, most of surgery stopped. Not all, and we'll come to that later. So, it stopped because the capacity went elsewhere, and it stopped because people were terrified of elective surgery patients getting COVID. And in fact, there are now some studies showing that if you are unfortunate enough to contract COVID post-operatively, you may have a mortality rate approaching 20 or 25%. So this has obviously put a big stopper on surgery, which is creating a really pretty massive task. Some recent modeling from a group in Birmingham published in the British Journal of Surgery suggests that about 36,000 patients are waiting for surgery, which has been cancelled for cancer. So we have a backlog. And we're worried that as the patients wait, the cases may become more complex. And Sarah has already mentioned those undiagnosed, and with their waiting, those cases may become more complex. So surgery's got a big problem. In a way, an operating team is an ideal incubating zone for COVID. We need a COVID-free patient. We need a COVID-free anaesthetist, surgeon, theatre staff, maybe an ICU to go to afterwards, obviously the nursing staff on the ward, and the diagnostics. And this is all a major, major logistic challenge. We are discussing, and this has already happened in a number of places. For example, the Royal Marsden's been able to do it, and in Oxford, where I am, they've been able to do it. If you have two hospitals side by side, for example, in Oxford, we have an emergency side and we have an elective side. The emergency side has been kept COVID light. So the plan is to develop as many COVID light sites as possible so that we can provide that safe environment, both for the patient and the staff, to come in and have safe surgery. There's already evidence that if you come into that kind of COVID light environment, mortality and complication rates are no greater than they have been before COVID. So here's an issue. We need to have that kind of capacity, and maybe that will be provided by surgeons and staff working more hours, but there's a major, major issue around theatre nursing staff. We may need to keep the independent sector open for longer. And of course, the idea of the COVID light site isn't always possible in every acute district general hospital. And so there may be some very difficult decisions to be made about, if you like, the restructuring of services. So there are some interesting research projects going on, both about the complications of COVID, but also obviously as we use minimal invasive surgery to try and reduce the surgical, if you like, insult. There's a lot of interest in aerosol generating procedures. Do we, when we do, for example, keyhole surgery, generate an aerosol which might spread the virus around? That's just one issue. If we get through a successful operation, where do our more elderly patients go and recover afterwards? A massive issue. If the beds are blocked, then again, that's going to have a huge effect on capacity. And as much has been said already, there is a big issue about patient fear. If patients hear about adverse outcomes related to the virus, they're not going to want to come into hospital. What can we do about the surgery itself? I think there's a lot of discussion about minimizing the surgical insult, but obviously we can't do that overnight. Much of our clinic work is being done by telemedicine now. The problems are formidable, but there has been terrific innovation, there's been great collaboration, and the Royal College of Surgeons has published a recovery plan, which includes lots of the issues I've been talking about, and I'll leave it there for the moment. Thank you.
Excellent. Thank you very much indeed, Neil. I'm very grateful for that indeed.